Okay. Well, good morning, and thank you for this opportunity to talk with you about human papillomavirus vaccines, opportunities as well as challenges. I have nothing to disclose. So I just wanted to start with a scenario that might sound familiar to some of you when making a recommendation for HPV vaccines. You were talking to a parent who asks you about HPV vaccine for her 11-year-old daughter and 13-year-old son. And when you make your recommendation, she responds, "I'm fine with the pertussis and meningitis shots. I don't think my daughter needs the HPV vaccine yet, and I don't see any reason for my son to get the vaccine at all. Plus, I want to wait until we know for sure that the vaccine is safe and actually works." How do you respond to all of the concerns and questions that are wrapped up into that response? So my goal today is to provide some information to help effectively answer these questions through a review of current trends in HPV-related disease, as well as vaccine safety and effectiveness, and the current HPV vaccine recommendations in light of the relatively newly introduced 9-valent vaccine, and then to spend some time identifying other key barriers to HPV vaccine series initiation and completion among males and females, and then lastly to review what we know about effective strategies to improve implementation of HPV recommendations amongst males and females. So to start, I just wanted to review HPV epidemiology. As many of you probably know, this is the most prevalent sexually transmitted infection. Almost everyone, 8 out of 10 men and women, are infected at some point in their lifetime, with about 14 million new cases per year. And particularly of importance when we think about current recommendations for HPV vaccines and children we may take care of as pediatricians, HPV does disproportionately affect youth. So 3/4 of new infections occur in adults and young adults, and about 1/4 of 14 to 19-year-olds are infected with at least one HPV type. And so if you think about how this might align with likely exposure risk, these are data from one of the behavioral risk factor assessments that the CDC implements every few years. About half of teens by the time they graduate from high school are sexually active, so have an opportunity for exposure to HPV. And about 6% had sex even before the age of 13. So youth are affected by HPV, and even disproportionately so. And one of the reasons why that happens is because HPV is acquired shortly after becoming sexually active. And so if you look at adolescents, the median time to first HPV after initiation of sexual activities is about 3 months. And then these are also some data from a cohort of women looking at the cumulative incidence of HPV after sexual initiation, and about 30% acquired HPV by 1 year and 50% by 3 years. And the risk of HPV acquisition occurs even with the history of one partner. So no matter how long one may wait, even with one partner, the risk of HPV after exposure can happen fairly quickly, and which I think really underlies the importance of early protection. So there are about 130 known serotypes that invade both cutaneous or skin cells, as well as mucosal cells of the anogenital region, the oropharynx, and the esophagus. This is a virus that can live in many different places. And while for the most part, when we're infected, infections spontaneously resolve largely before we may even know we're infected. But if you do have persistent infection, particularly with oncogenic types, this can progress to neoplastic lesions. And so we now have genetic and epidemiologic evidence suggesting that HPV is a necessary cause of cervical cancer, but is also strongly associated with a wide range of other anogenital cancers. And there are about 27,000 cases per year in the U.S., with a much higher burden globally. So what does this look like if we look at HPV-associated cancers in females? Of course, cervical cancer does comprise the majority, about 2/3. About a third of HPV-related cancers in females also occur in the vulvar and anal regions, and a sizable proportion in the oropharynx as well. And if you look at trends over time, there's been an increase in the incidence of oropharyngeal and anal cancers, while there's been a decrease in cervical cancers, though importantly, persistent sociodemographic disparities. And HPV certainly affects males as well, and you can see here there are just under 10,000 oropharyngeal cases per year, the majority of which are attributed to HPV. And again, looking at trends over time, the rates of oropharyngeal cancers are increasing, and it's, I think, estimated that rates may even overtake those for cervical cancer. So in addition to HPV-associated cancers, HPV, of course, does also cause genital warts, which is associated with a significant morbidity. It happens very commonly in about 1 in 10 individuals in their lifetime. And there is a high recurrence rate after treatment. Genital warts are difficult to treat and also can contribute to ongoing transmission, particularly because you can have transmission when symptoms are not evident. And particularly of importance in pediatrics as well, infants born to women with genital warts can develop respiratory papillomatosis, which is a rare outcome, but again associated with significant morbidity. And so prevention can have quite an impact. And when we look at our current prevention strategies, at least alongside, and in addition to having an HPV vaccine available, we've had Pap screening, as the cornerstone, at least, of cervical cancer prevention for several years, and it's been quite effective in reducing the incidence of cervical cancer. But there are disparities, in countries, including the U.S., with well-established Pap smears, Pap programs, and so particularly, women who may be at even higher risk of developing cervical cancer may be less likely to participate in Pap screening programs, and such programs are really non-existent in most low and middle-income countries. And then, as we just saw a few slides ago, HPV-associated cancers do occur in other locations, and we really don't have a great screening program for a non-cervical HPV disease. And then lastly, even with screening, subsequent treatment and management of these precancerous lesions is costly. It's associated with morbidity. And then other interventions such as abstinence and condoms can be effective at reducing risk, but condoms in particular do not reduce risk by 100%, as you can still have transmission even if you use them regularly. And then, of course, at the population level, there is not consistent use, and this really does restrict their overall ability to reduce transmission. So vaccination really does represent an excellent opportunity for prevention. And so, HPV vaccines were introduced in 2006 and have proven really to be an effective tool. So HPV vaccines are made using what we call recombinant technology. So essentially, what they've done is taken the gene that encodes for one of the capsid proteins from the outside of the virus, and this is one of the proteins that we mount an immune response to, so it's an immunogenic protein, and essentially clip that gene and insert it into yeast cell DNA, and then those yeast cells can make lots and lots of those viral capsid proteins, which then can reassemble into an empty virus, essentially, something that looks like a virus on the outside but has no active genetic material on the inside, and so is able to really elicit a nice robust immune response. But it is not a live virus vaccine, and this is similar to the way in which hepatitis B vaccines are made. So we now do have 3 different HPV vaccines. Of course, I won't spend too much time, going through their relative indications or schedule. Of course, most recently, the 9-valent vaccine was approved and introduced in December 2014. And has added 5 serotypes to the breadth of coverage offered by HPV vaccines. And those 5 serotypes, increase the amount of coverage or the amount of serotypes coverage for the causes of anogenital cancer. So with the 9-valent vaccine, we cover an additional 11 to 15% of anogenital cancers in females and 4 to 9% of those in males, and an additional 4 to 9% of oropharyngeal cancers in males and females as well. So really increases the proportion of cancers we may be able to prevent. And when we think about efficacy, even in pre-licensure studies, all of the data did show a very impressive efficacy profile, about 90 to 100% in preventing multiple precancerous lesions, anogenital warts, as well. Also have shown an even more robust immune response in younger age groups, and so 9 to 15-year-olds have about a twofold higher antibody response compared to older adolescents. But again, this is, of course, a prophylactic vaccine, and so the vaccine will not prevent disease if you're already infected with any one of the vaccine types at the time of vaccination. So again, underlying the importance of early protection. HPV-9 has also proven to be efficacious and safe as well, showing excellent immune responses to each of the additional 5 serotypes that is not impacted at all by previous immunization with HPV for the quadrivalent vaccine as well, and HPV-9 can be given concomitantly with the other adolescent vaccines. And so, the other, there's been more and more, we have more and more data now that the vaccine has been introduced and implemented in immunization programs worldwide, we've really been able to see more and more of vaccine effectiveness or evidence of vaccine effectiveness. And so these next few slides just summarize some of the data showing the impact of vaccination, both at the population level and individual level as well. And so these are relatively early data. This is an article from 2013 summarizing incidence of or prevalence of genital warts in women in Australia before and after introduction of the vaccine. And you can see a steady and persistent reduction in prevalence, particularly amongst adolescents in whom the vaccine is recommended. And this is again at the population, across the population. These data are from the U.S. and demonstrate effectiveness really at the individual level, showing prevalence of vaccine types 16 and 18, which are associated with about 70% of cervical cancers, and so showing a persistent reduction over time since vaccine introduction amongst vaccinated women compared to unvaccinated or women in whom their vaccine status is unknown. And so these are all age-eligible women, or age-eligible for vaccination women. And then lastly, this is a more recent article. This was published in Pediatrics, I think, earlier this year, again showing impact at both the population and an individual level. And so this summarizes HPV prevalence, in particular the 4 types included in the quadrivalent vaccine, comparing prevalence before and after vaccine introduction. And again, as you can see here, in younger adolescents, of a significant reduction in HPV type prevalence from 11.5 to 4.3%, and a significant reduction as well in older adolescents. And then the study also looked at a cohort of sexually active teens from the ages of 14 to 24, adolescents ages 14 to 24-year-olds, again showing significant vaccine impact. And so the HPV prevalence was 2.1% in vaccinated compared to 16.9% in unvaccinated sexually active females. So this is a cohort at risk for exposure to HPV, and so demonstrates the ability of the vaccine to prevent infection. Importantly, the study also showed no significant reduction in non-vaccine type prevalence to suggest no real cross protection. And then lastly, there are also some data demonstrating long-term effectiveness, and so these are interim analyses from the extension, phase 3 extension trials. So these are all from the initial vaccine trials, and follow-up has continued even post-licensure. And so these data show impact on some of the more long-term outcomes as well, clinical outcomes. And so in this first trial of about 1,900 females with a median follow-up of about 7 years, there were no cases of any vaccine type-related cervical, vulvar, or vaginal cancers observed, or intraepithelial neoplasias as well. And then in another trial, this was amongst males and females, a little bit smaller, again 7 years of follow-up, and again no cases of any vaccine type related have thus far been observed. So quite a bit of data in support of vaccine effectiveness, both at the community and individual level. Vaccine safety has continued to be another important consideration. In general, the safety profile for this vaccine is excellent. Their pre-licensure, the vaccine safety profile is excellent, and post-licensure continues to be strong as well. There have been almost 70 million doses given, at least as of March 2014, and only a small proportion of those resulted in reports of adverse events, the majority of which were non-serious. And there have also been 3 large post-licensure observational studies, as well as in many other ongoing vaccine safety activities that really are just part of our vaccine safety infrastructure for more than 8 years among 1 million people. So a lot of data that have looked at a wide range of outcomes and have shown no significant associations with any of these outcomes except syncope, which was found to correlate with vaccine administration. It really is not necessarily specific to HPV, can occur with the administration of other vaccines as well. But serious adverse events have tended to be very rare, and upon further investigation, been shown to have no increased risk among vaccine recipients compared to those who have not received the vaccine. So our recommendations, of course, I'm sure everyone is very familiar with current recommendations, for routine administration to 11 to 12-year-olds, which allows for its placement with the other adolescent vaccines that are part of the adolescent vaccine platform, and to with catch-up vaccination of older adolescents as well. HPV-9 was licensed and added to the current recommendations in 2014. And in terms of current recommendations for the use of HPV-9, at this point, as HPV-9 is being incorporated into current schedules and available vaccines, the ACIP does not express any preference of which vaccine to use. A series has already been started with either the quadra or bivalent vaccine can be completed with HPV-9, and if that option is selected, there's no routine recommendation, at least for giving additional doses if you are completing a series with HPV-9. So if you have a patient who's already received 2 doses of the quadrivalent vaccine, you can finish the series with HPV-9. There's no specific recommendation to give an additional dose. And nor is there a routine recommendation for giving HPV-9 to individuals who've completed either HPV-4 or to the bivalent or quadrivalent vaccine. And then along with these recommendations is, of course, to continue ensuring routine cervical cancer screening for women. And that is because even though especially with the 9-valent vaccine, we do have broader coverage of the types associated with cervical cancer. It doesn't include all types, and so it's important to continue screening. So what were some of the considerations that influenced recommendations from the ACIP? Overall, available data has not shown any significant safety concerns amongst those who have received HPV-9 after completing the quadrivalent vaccine series. And so there aren't any safety concerns in the administration of one vaccine series after another. But there are also some considerations from a cost effectiveness perspective, especially when thinking about whether to make a routine recommendation. And so one of the issues is that the benefit of the 5 additional serotypes does primarily affect females compared to males. So there's broader coverage amongst females compared to males. And then when considering the cost per quality gained, there's a relatively high cost per quality gained if we were going to implement a routine recommendation for an additional completing a series amongst adolescents who had already completed a quadrivalent or bivalent series. So at this point, I think it's been at a provider discretion about how to incorporate HPV-9 into their current recommendation practices. Just a couple of notes about dosing intervals, contraindications. There really are significant contraindications to HPV vaccine receipt, outside of an allergy to any one of the vaccine ingredients. This question has come up fairly somewhat frequently, whether or not a history of sexual activity or previous HPV infection, should influence, whether someone should get the vaccine. And it is not a contraindication to vaccination. And there's still the vaccine can still, have be effective and have impact, because it is unlikely that a teen would have been exposed to all of the serogroups that are included in the vaccine, so there still would be protection. And then otherwise, the vaccine should not be given during pregnancy. This is largely just because we do not have much safety data about HPV vaccines during pregnancy. When it has happened inadvertently, there have been no reports of any significant adverse events, but at this time we don't have any enough data to support a recommendation that it's okay to vaccinate during pregnancy. So at this point, it is considered a contraindication. So another reason why dosing, of course, the dosing interval, it is a 3-dose schedule, and really this is to allow for an initial priming doses to be followed by a booster dose after about 4 to 6 months of the initial dose, to allow memory B cells to mature and differentiate. And so, in practice, if you are trying to give the 3-dose series and the intervals are prolonged, there's no need to restart or repeat doses, although that would need to happen if the intervals are shorter. And so another issue or question that has come up related to the dosing schedule is whether a 2-dose schedule would allow for comparable efficacy. And so again, I think the important consideration related to a 2-dose schedule is making sure that you allow for enough time in between 2 doses for a prime and a boost. And so 2-dose schedules have been evaluated in some trials, as well as other studies that have looked at longer intervals and have shown comparable efficacy. And in fact, in April 2014, the World Health Organization recommended a 2-dose vaccine schedule with a minimum interval of 6 to 12 months, as long as the schedule has begun before the age of 15 years. And I think that is because of the more robust immune response in younger teens. And so that is a recommendation that was put forth by the World Health Organization, and has resulted in approval in many other countries across Europe, Asia, Africa, and Latin America. And so this has been important from a program implementation perspective in many places. So here in the U.S., what about a 2-dose schedule here? And so at this point, we don't have an approved 2-dose schedule for either the bivalent or quadrivalent vaccine. And so at this point, as per our current indications and approval, a 3-dose schedule is what is recommended. But a 2-dose schedule has been submitted for approval for the 9-valent vaccine and is under review. And so we may see some changes soon regarding our schedule and dosing intervals. So we have a safe and effective vaccine. But as you can see here, how are we doing for uptake? Of course, I think as we all know, we continue to struggle. And so as you can see here, we have HPV series initiation rates that have really been hovering around 50 to 60% for females, and have been rising for males. This is a later recommendation for routine administration to males, but for both males and females, rates remain well below those for the other adolescent vaccines, and below the Healthy People 2020 goal of about 80% coverage. And also importantly, I think when we look at our rates for HPV vaccination, we see a lot of missed opportunities as well. And so, why do we have this gap? It appears that there are times when we are, missing opportunities to give HPV. And so, whether it's teens who are coming in for a visit and maybe receiving the other recommended vaccines, and HPV is deferred, or teens are coming in for acute visits and are not being vaccinated during that time, we're missing opportunities, and that's had a significant impact on coverage. You can see here this is a modeling of what we could potentially achieve if we were able to meet all opportunities to vaccinate. And as you can see, we probably would achieve our target of about 80% coverage. So, why do we continue to have a persistent discrepancy in our rates for HPV and other adolescent vaccines? And so there are many challenges to vaccination, and many of these challenges are well described. There have been multiple studies that have sought to elucidate what some of the key facilitators and barriers to HPV vaccine uptake are. Some of these are related to access, in particular for adolescents who are less likely to seek out primary care services, so there may be fewer opportunities to vaccinate. That again, we do have missed opportunities. Teens may be more likely to present for sick rather than preventative visits, and at least we've seen when we've looked at who gets vaccinated and who doesn't in our network, that presenting for a preventative or well visit is highly associated with increased likelihood of receiving HPV. So may not really be giving HPV during other visit types. And then also just the ability to identify eligible patients, to know who needs to be vaccinated and who may have already received the vaccine. And we've had many places have registries that help in that identification. At least traditionally, some of those registries might not always have included adolescents. So provider recommendation is another important category that significantly contributes to vaccine acceptance. Overall provider recommendation, just in general, not just for HPV, but for any other vaccine, is probably one of the most important predictors of vaccine acceptance. But we do know that clinicians are more likely to recommend vaccine to older adolescents compared to 11 to 12-year-olds for whom vaccination is routinely recommended, and may not always present HPV in the same way that they present pertussis or Tdap or meningococcal vaccines, and so that the vaccine can sometimes present it as an optional vaccine, which may influence acceptance and uptake. There could also be considerations about perceived risk of HPV among patients. HPV is certainly not something that pediatricians often see clinically or diagnose, unless they tend to work with a lot of adolescents or deliver STI or family planning services, and so it may be harder to see, this is what the outcomes of HPV may be, compared to something like meningococcus or pertussis, for whom many pediatricians have seen cases. Clinicians can also have their own vaccine safety and efficacy concerns. When we have looked at, this was shortly after the first vaccines were licensed and introduced, predictors of intent to recommend vaccine to both younger and older teens. And one of the most important predictors were beliefs about vaccine safety. And so we can have our own concerns about vaccine safety, especially for newer vaccines. And then, of course, there are financial concerns and reimbursement concerns because this is one of the most expensive vaccines. Then lastly, the other important category is related to parental acceptance. And so, even with a provider recommendation, parents may still decline vaccination. And, some of this is maybe due to, a concern that, this vaccine is just not necessary yet. I'm sure it's great to be able to prevent cancer, but, this is still a sexually transmitted infection. My child's not sexually active. They just don't need it yet. We don't want to start having to talk about these things yet. And so, will defer or decline vaccination because they don't think it's necessary. May also have vaccine safety concerns. There have been a lot of vaccine safety concern kind of circulated in kind of popular media and social media channels. Many of these, not unfounded and related to misinformation, but still have contributed to persistent vaccine safety concerns that can contribute to hesitancy. And then I think also just a general lack of knowledge about HPV risk, especially for adolescents, and HPV and its association with cancers. I don't know if many of you have seen the Someone You Love documentary, but one of the things that I was struck by is that in, I think, every one of the cases, or most of the featured stories, women said that they did not know what HPV at the time of their diagnosis. Did not even know what HPV was, or that HPV was associated with cervical cancer. And so I think we learn a lot about other STIs, but probably less about HPV. And then lastly, there could be just other issues that are related to vaccine hesitancy in general. Trust and confidence in the health system as well. So many challenges and barriers. These are just some examples of some of the available data, highlighting what some of the barriers may be. This is from the National Immunization Survey, and I included these just because you can see the trends over time in terms of reasons for not vaccinating. First, there's a sizable proportion of parents who report that they do not intend to vaccinate their child, and that really has remained steady over time at about 40%. And then when you look at reasons for not vaccinating, still a fairly high proportion just feel like the vaccine is not needed or necessary. Then when you look at safety concerns, interestingly, you see that those proportions have increased over time. When you usually with a newer vaccine, as there's more experience with that vaccine, you would anticipate the concerns about vaccine safety might decrease. And that has not been the case with HPV. And then also just looked at whether reasons may differ for not vaccinated females versus males. And for the most part, many of the reasons are the same, but as you can see, parents of males were more likely to report that vaccination just was not recommended for their male child. So, what can we do to address some of these barriers? In the same way that there have been multiple studies to elucidate barriers to uptake, there is a growing body of literature evaluating different interventions to increase both vaccine series initiation and completion. And these interventions may target parents and teens or both, providers, may target practices or communities. And fortunately, there have been some recently published systematic reviews that provide nice summaries of results of some of these studies, which I think can help guide our thinking about and discussion about what may be some best practices to try to improve vaccine uptake. And I think we have made these systematic reviews available if there's an interest. So what is current evidence? So one of the first set of interventions is really related to addressing the barrier of access and getting patients to clinic. And the primary approach for that really is related to reminder recall initiatives. So how can we get teens to clinic? And so in one review, there were about 7 studies that looked at many different modalities for reminder recall, including text message reminders, particularly for second and third doses, using mailed letters or postcards, phone calls, and outreach visits, or a combination of some of these strategies. And all of these showed a modest but significant increase in both initiation and series, and in receipt of the second and third doses. And overall, increases in series initiation and completion range from about 6 to 16% across these included studies, suggesting that reminder recall efforts, may be effective at getting teens to clinic, either to be able to give them a recommendation to start the series, or to get them in so they can finish the series. And these are just data, this figure from one of those studies that looked at text message reminders. And so the dark bar represents those who had signed up to receive text message reminders, and there was a consistently a higher proportion in that group who did receive a vaccine dose, their next vaccine dose, compared to those who did not receive that text message reminder. So physician-focused interventions have also been evaluated as well, and the main goal of many of these interventions is to really prompt or encourage a recommendation in order to prompt series initiation in particular, and as well as to support physician communication with parents, particularly if there are specific concerns that are brought up at the time of a recommendation. And so some of these interventions may include decision support strategies for providers to prompt recommendations, such as using EHR alerts to identify patients who were due for adolescent-specific vaccines, including HPV, or assessment and feedback interventions, in which a clinician's own immunization practice is shared and compared maybe to colleagues or other practices. And this may be done within a network, or there are also assessment and feedback programs through the Vaccines for Children program, such as AFIX. And then also just education and training. So, for example, providing CME opportunities related to HPV vaccination to hopefully provide information that can help strengthen a recommendation. So how well did these perform? So overall, at least in one systematic review, these efforts have shown to increase vaccination rates in 6 of the 7 studies, so suggesting that focusing on physician-focused interventions may also be effective. And then, other work suggests that multiple strategies may be needed, that it probably won't be just one to really optimize rates. And so reminder recall initiatives can get patients in, but physician-focused interventions may really help with that initial recommendation to prompt initial vaccine acceptance. And so as an example, these are results from a randomized trial of a both clinician and family-focused intervention. This was carried out by one of my colleagues in our network. And so the clinician-focused intervention included decision support, which was an EHR prompt, as well as audit and feedback, in which each provider was given their own kind of performance, so the proportion of eligible teens that they'd seen during a certain period of time, what proportion of those teens were vaccinated, and how that compared to other clinicians at their practice site, as well as education, a CME opportunity. And then for families that received an automated telephone reminder to alert them of an upcoming visit, and that their child may be due for vaccine, that their child was due for vaccines at this visit, and then also they were given information about a link to a vaccine education website. And so overall, the clinician intervention had the largest impact on receipt of the first HPV vaccine dose, while the family intervention had the larger impact on receipt of doses 2 and 3. And overall, it was the combined intervention that had the highest impact overall. But really suggests that having a multiple strategies, a multi-pronged approach may be most effective. So there have been also some efforts to try to reduce missed opportunities, and so this can be achieved in many ways. So one is really to try to do what we can at the practice level. So having standing orders, for example. So when especially if an adolescent is coming back for a follow-up or just needs to schedule their follow-up visits to receive doses 2 and 3, to have the orders already set. which can make it easier and more efficient for vaccine administration. To vaccinate at both sick and well, or acute or non-well and well visits. If a patient has a mild illness, they can still receive the vaccine, or if they're coming for another reason for a sprained wrist or something like that, they could still potentially be vaccinated. So just to take advantage of every encounter. And then also reducing missed opportunities could include consideration of alternative locations for vaccine administration, such as schools or even pharmacies. And so there have been a couple of trials or pilot studies to look at school-located adolescent vaccination clinics. Two of these studies showed evaluating such clinics showed a significant increase in vaccine receipt, from about a 5 to 16% difference. So suggesting that this could be one potential strategy, though this, of course, does require being able to establish a partnership with a school district and having enough resources to provide immunization services. And there have been a couple of studies that have also tried a similar approach, even related to influenza vaccination in school-age children. And to be able to really facilitate the ability for some of these different strategies, it is important to consider what kinds of policy changes that would require. So, for example, if a consideration to perhaps provide HPV vaccination, particularly for doses 2 and 3 in pharmacies, as an example, this may require changing state regulations to allow adolescents to be vaccinated in pharmacies. And as well as ensuring consistent coverage and to try to close gaps for un- and underinsured as well. And this is implications in particular for adolescents over the age of 18 who may not who no longer qualify for the Vaccines for Children program. So other policy approaches that could help improve uptake in general, whether it's at an alternative location or and within a primary care site, is to also consider consent requirements to allow teens to be vaccinated without parents being present. So, teens can, for the most part in most states, seek out care for confidential health services, but can they also be able to receive HPV vaccines as well? And so there is a statement from the Society for Adolescent Medicine suggesting that healthcare sites develop procedures that can enable minor adolescents who present for routine or confidential care without a parent to receive recommended vaccines based upon either minor consent or previously obtained parent consent within legal requirements. And so, this would facilitate an ability maybe for, especially if for a teen who's already started the series, perhaps they got their first dose at a well visit, they can come after school, on their own to receive doses 2 and 3. So the last potential policy approach it could be considered, as a way to influence uptake is related to school entry requirements. And so, school entry requirements are one of the primary features, certainly a cornerstone of our immunization program in general, and is likely has certainly influenced some of the. It certainly, I think, influences of acceptability in some of the high rates that we've been able to achieve related to vaccination. And so since 2006, about 41 states and the District of Columbia have introduced some kind of legislation to either require vaccination or HPV vaccine funding or HPV education. And although many states have introduced legislation, only 2 states in D.C. Really have mandatory policies for school entry at this point. Both Virginia and D.C., though, have liberal opt-out policies. And Rhode Island's policy is probably the most stringent. It requires vaccination for girls and boys and only allows medical or religious exemptions that have to be submitted in person and completed by a healthcare provider. And so, should mandatory requirements, and what are some of the considerations, I guess, in support of mandatory requirements And so certainly they contribute to both equity and accessibility. If everyone who's going to school has to be vaccinated, then everybody is going to get the vaccine. And so that really can help address some disparities in vaccine receipts. And then also, if you just consider from a public health perspective, the potential severity of HPV-associated of HPV infection and the prevalence of HPV disease across the community, ensuring that adolescents are vaccinated at the time of school entry can certainly help achieve high rates across a community, which can really have an impact on transmission and disease prevalence. And then also just the consideration, the ethical principle of non-maleficence. I mean, this is a highly effective and safe vaccine with an excellent safety profile, and so and it's an available tool. So to ensure that as many people as possible have access to can receive that tool. Mandatory policies do support that principle as well. But considerations against it, but again, only two states in D.C. are the only ones that have really been able to pass legislation. There have been other forces pushing against a mandatory entry requirement, particularly for HPV. And so some of that it just has to do with, at least initially, this was a newer vaccine, so there may have been concerns. We need more experience with this vaccine, but now it's really been available for 10 years. And then also just the consideration of, HPV is something that's not transmitted in a classroom. Yes, it is highly prevalent infection overall, but for the most part, the vaccines required for school entry are those that are, highly communicable and can be highly communicable within a school setting, like pertussis or measles. And so, HPV does not necessarily fit, fit that profile from a public health perspective. And then also the pushback is also just related to parental autonomy. Some parents not feeling comfortable having a vaccine required that is also related to for a disease that's related to sexual activity. So we don't have a lot of places with mandates, though there continue to be states that consider including them as for school entry requirements or localities. And so have mandates had an impact? So as I've mentioned, both DC and Virginia have fairly liberal opt-out clauses, and so their rates had not significantly increased the implementation of mandates, and so suggesting that a substantial proportion of parents have exercised the option of an opt-out clause. Interestingly, DC now requires annual exemption filing, and so since that time, their coverage rates have actually increased in serious initiation quite significantly. Rhode Island, on the other hand, that has kind of stricter implementation of their mandatory policy, I believe, does have higher rates. And then there are also, if you look overall, rates are higher in states that don't have mandatory school entry requirements, but that distribute the vaccine at no cost. So suggesting that other ways to increase access may also be effective. And then if you kind of look at other places, so for example, the United Kingdom, I think Australia as well, they have high rates of coverage, but here the vaccine is free and it's distributed in schools, but there's no requirement for school entry. So it's perhaps easier to get, but have also been able to achieve high rates without a mandate. So a mandatory policy may have the potential to influence uptake. But other strategies may also be effective. I think here in the U.S., because we do use mandates, sometimes when a vaccine is not required for school entry, it may be kind of viewed a little bit differently. So a parent may say, well, if it's not required for school, then it's not as important, so I'm not going to get it. So the message may be a little bit different here compared to other countries. So other efforts have really focused on more at the community level, public education and awareness. And so there is a prevention and public health funds. They've given out grants to different states for research and localities. to develop outreach programs to increase HPV vaccination rates. These included social media strategies, using radio and TV ads, reminder recall initiatives, in particular centralized reminder recall initiatives, leveraging registries, as well as provider education. So again, a multifaceted approach. And these, for the most part, have been shown to be highly effective. In Chicago, initiation rates increased by about 20 percentage points amongst boys and girls. And Philadelphia, who had also received one of the grants, showed an increase in rates that has now placed them, I think, at the highest in the country, highest initiation and completion rates, at least among females in the country, at about 80% for initiation. And so this is an example of a public education and awareness campaign. This is a You Don't Get It campaign. This was not part of some of those aforementioned state grants, but this is an initiative that is supported by multiple collaborators, including this state chapter of AEP in Pennsylvania, called the You Don't Get It campaign. It's a series of videos and other tools targeting high school, middle school students and providers that have been distributed in all but one county in the state, primarily through school nurses. And so these kind of efforts, I think, can be potentially effective because they, I think, really leverage social marketing principles. So to think about the images that are used and how they are placed to really try to change how vaccines are valued. And so this can be highly effective, I think. So for example, if you look at this reminder recall postcard, it is about getting teens in for vaccines, but the imagery is all about happy and healthy teens. And then for placements, here, this is Facebook, of course, so that's, trying to leverage social media. And then you have, this message about getting your teens in for vaccines, painted on the side of a school bus. So, that's not even a school bus, a public bus. So it's, something that everybody sees as they're, walking to work, going to school. And so it kind of almost normalizes this idea of, yes, my teen needs to be vaccinated. This is and it becomes a kind of a part of something that you see every day. So I think some of these initiatives have the potential to be effective, for those reasons as well. So communication is another, the next important category related to addressing barriers. I wanted to turn to, and this is really important. I think brings back the importance of a provider recommendation. And so there have also been, there's a growing body of evidence trying to look at ways to try to strengthen provider recommendation and effectively address parental concerns as a way to improve rates. And this is largely because, as I've mentioned before, provider recommendations are the most important predictor of vaccine acceptance overall. But, a provider recommendation, when you make it in the office, is also occurring within a context. And so, parents are coming into the room with likely having been exposed to information from a lot of other sources. Some of these sources being more supportive of vaccination, that are evidence-based, and some of the other sources may not be as supportive of immunizations and may raise a lot of questions for parents as you're making your recommendation. And so this can make the way we make recommendations challenging. And so even though a strong recommendation is important, we also know that the strength of recommendation specific to HPV can vary. And so these are data that are from a few years, they're a few years old now, but show that pediatricians and family practitioners, they're more likely to make a strong recommendation for older compared to younger teens. And so, what can we do to try to improve the strength of our recommendations overall? And so, why does this matter? Is, provider recommendation can prompt acceptance, but a strong recommendation in particular appears to potentially influence acceptance. And so, these are results from a study. This is not specific to HPV, but this was a small, relatively small trial of a cohort of providers. And essentially their recommendation style. And so interactions with parents were followed, with this group of providers. This is an observational study, and the investigators compared the rate of vaccine acceptance amongst those whose providers use what we call a presumptive approach. So that was, your child is due for these vaccines today. I'm order these vaccines, or I'm recommending these vaccines. And the participatory approach was more, these are vaccines that are recommended. What do you think about the vaccines? And so, as you can see with these results, those in the presumptive group were more likely had a higher acceptance rate compared to those in the participatory group. Only 4% of those in participatory group accepted the provider's recommendation, suggesting that the strength of recommendation can matter. Now, again, this was an observational study, and certainly the provider may have chosen their recommendation style based upon what they anticipated a parent may say. But I think does at least provide some support for making a strong recommendation. So making it strong, not red flagging HPV vaccines, to talk about it in the same sentence as the other adolescent vaccines, and then to also help parents understand the risk for diseases prevented. So the reasons why you're making a strong recommendation, why HPV is important. And then, of course, as much as possible, the same thing that you probably already do for recommending any vaccine is trying to personalize the discussion as much as possible and emphasize common grounds. So, again, even with the provider recommendation, parents may still present, many kind of questions and concern that will need to be addressed. And so, how can we effectively address those barriers as we're talking to parents? And so these next series of slides really just to provide some messages to help address some of the key concerns. And so the first is really, are you sure that the vaccine is safe? And as I mentioned, there continue to be vaccine safety and concerns and stories that circulate about HPV vaccines. This is just one example from the last election presidential debate, when Michelle Bachmann, during a debate, brought up a story that she'd heard about something that happened to a woman's daughter after she received HPV vaccine. And of course, this was on national television. There have been stories on CNN, the cancer vaccine scare. So it's hard not to respond to those. And so I think here, as much as possible, to emphasize how much we really do know about the safety of HPV vaccines, and that this is a vaccine that has been evaluated for several years now, both pre and post licensure, and more than 1 million people, and that there have been several specific outcomes that have been evaluated, and then to acknowledge the known side effects. 1 in 60 develop mild fever. That you can expect to, many will develop some pain and swelling discomfort around the injection site. And then, of course, syncope can happen as well, because you're going to have the teens sit for 15 minutes. Sometimes parents may ask, well, how long will immunity last? Why am I vaccinating my 12-year-old if, they need to be protected, when they're, in their late adolescence, early 20s. And so, I think we have, as much observation time as the vaccine has been available. At this point, we don't have any evidence of waning immunity. And if you think about how the vaccine is made, this vaccine probably should induce pretty, long-lasting immunity. It is, again, similar to the hepatitis B vaccine, which does induce long-lasting, essentially, lifelong immunity. So. There should be persistent immunity with HPV vaccines, and so can provide that reassurance. And then, of course, the question of, well, does the vaccine increase sexual promiscuity? So this vaccine there's been no evidence that HPV vaccination has been associated with any increase in sexual activity. And so there have been a couple of studies that have really specifically looked at that, so compared the frequency of seeking out services for STI testing and treatment, pregnancy testing amongst vaccinated and unvaccinated girls, and I've seen no difference in the frequency of seeking out these services or diagnosis of any STIs. And there are some other studies as well that have shown no difference in risky behavior, perceived risk of getting an STI, and so does not look like HPV vaccine has any impact on sexual activity. And then again, of course, the most prominent reason for not vaccinating is this vaccine is just not necessary right now. So, why can't we just wait until my child's a little older? Like, what's the rush? And then here, I think you have an opportunity, and if our goal is to reduce missed opportunities, that and emphasize that you have an opportunity for prevention now to start the series when they're here for their other vaccines, and that there really is no benefit in waiting to initiate or complete the vaccine series. That early vaccination really is the best way to ensure protection before exposure. You can also talk about the stronger immune response in younger adolescents as well. And then, again, it just lets you kind of leverage the adolescent vaccine platform. So, what's the best way to communicate all of these messages? So, provider recommendation is important, but you're also maybe providing, some education related to the concerns that parents may have. And so, there's been and it's hard to do that in a visit. So, ideally, there'd be other ways to be able to provide some of this information, even before or during your visit. And so a systematic review of 33 studies evaluating some educational interventions actually have shown little impact on HPV vaccine initiation and very modest impact on attitudes and intention. And so these efforts have included either parent-focused or adolescent-focused education using out of fact sheets or slides and videos, and even have thought about different ways to frame messages, using narratives, using infographics, talking about more of the benefits of vaccination rather than the risks of HPV disease, in lots of different ways to try to see what works the best. And so I think the lack of strong impact likely shows that the fact that effective communication probably requires consideration of both kind of what you're saying and how you're saying it, and who the person is, the parent is, what drives their decision making. And so that has contributed to more of a focus on a more targeted messaging and motivational interviewing. And so, providing information, how much a difference does this make, just to kind of illustrate this fact. This is from a study, again, not specific to HPV, but a study that looked at how different types of information about measles changed beliefs amongst parents about MMR and side effects or vaccines and autism. And interestingly, and you may have heard about this study, it received a lot of media coverage, but parents who received a narrative about measles disease were actually more likely to report a belief that MMR causes significant side effects, as well as parents who saw images of a child with measles. And so that information did not appear to really change their beliefs. In fact, it went in the opposite direction. Suggesting maybe that messages about fear could potentially enhance already held beliefs that are kind of grounded in fear. But I think overall really underlies the importance of considering this idea of targeted messaging. So as much as possible to try to understand what parents are considering or regarding vaccine decision making, and then to think about messages that may match that. And so this is from a recent article that kind of looked at different types of vaccine hesitancy. Or vaccine hesitant parents, and so some it really might be really just about convenience. Others are really thinking more about what's the risk of the disease versus risk of vaccine, and so here you may really want to just spend time targeting specific concerns. And then those who are just kind of complacent, like what, my child's not at risk for HPV, and so here a firm recommendation and talking a little bit more about disease risk may be more effective. And so the other approach that's been, I think, evaluated more and more is this idea of motivational interviewing and really trying to actively elicit specific concerns, and that may be a way to more effectively engage parents, address their concerns, and increase vaccine acceptance. And maybe this may work better than just providing a fact sheet or brochure, because it's it's more interactive. You're eliciting their specific concerns and directly responding to them. And so there are a couple of approaches that are suggested related to this and have been part of communication toolkits, but these efforts may be difficult to teach, and studies actually have not shown a significant impact of these interventions on HPV rates. And that is maybe because communication style is difficult to teach. We all have ways that we communicate, and it can be hard potentially to change that. So we're implementing recommendations. What do we know? So we know that HPV affects just about everybody, that we have vaccines that prevent cancer for everybody, and these vaccines are safe and effective, and that early vaccination is important to optimize effectiveness, and that if we want to improve rates, a multifaceted approach is likely needed. So what do we know? What don't we know? And so there is growing evidence to support a wide range of interventions, but sustainability and generalizability could be challenging. And then in general, we have kind of rising vaccine hesitancy, which can be challenging in general to address as well. Available studies that we do have show modest effect size, and few of them target 11 to 12-year-olds. And then, also, the use of some kind of more innovative strategies like, mHealth, text messaging for teens, and other uses of technology. I think these strategies hold promise, but have not been widely studied. So overall, I probably still have more to learn about what's going to be most effective. But combining multiple approaches is probably going to get us the furthest now. So here are some resources and tools to help guide your work. There are a lot of resources from many different places. I thank you for your time and attention. If you have any questions, I'm happy to answer them. Thank you.